Thank you. All right. Hi, everybody. And sorry for getting off to a slow start. I hope everyone's well. I haven't done the routine check-in, but you can give me a 1 to 10 pain scale score, 10 being good and 1 being not so good. Okay. And I like to see that, Shri, you finally moved up from 6.
Effect of Marayur Munnar, ma'am. At least for today.
All right. Okay, I'll get right into it because today we have quite a distance to go. We're going to be talking about children in the context of illness, death, grief, and communication. So there's a lot to unpack over there. And I will, as usual, request your participation and, populate the chat box with questions, with reflections, and whatever else that you might feel that you need to share. And I know this will also have a lot of questions, so we'll stop from time to time and take those questions as we go along. Okay, so starting off, let me just say that this is by no means a comprehensive understanding of what it is that children experience in difficult times of illness, death, and grief. And I initially, the idea was to take you through very specific pediatric palliative care settings. But I find that before we go there, not many of us are going to be working in those settings. But I think a working knowledge of how to deal with children in these situations, irrespective of whether we are care providers in a professional way or even just family members, is a little bit more important. So it was a very conscious decision not to go into the interventions that we do in pediatric palliative care, but to really just talk about what do children experience at a time like this. Okay. Um, but I will sort of take you through some of the statistics and what do we talk about in terms of children and what is childhood. It covers everything from perinatal, neonatal, up to 18 years of age. Okay, so that's basically when we even talk about pediatric palliative care, this is the entire spectrum of age groups that we are looking at. And there is a tremendous need across the world globally for pediatric palliative care, children's palliative care, but the majority of this care is only found in high income countries. Over 126 countries have no known kind of pediatric palliative care. That is the current scenario as we speak. And at the moment, approximately 21 million children worldwide could benefit with some kind of palliative care support. And where do these needs arise mostly from? What are the disease conditions, perinatal conditions, congenital anomalies like Down syndrome or cerebral palsy, things like that, HIV, AIDS, and cancer. So a very wide array of illnesses, and also a lot of the autoimmune conditions that that children might have, or even degenerative conditions various muscular atrophies and so on. So. Like I said, the need is very, very high, and the current uh, services available for pediatric palliative care globally are very low. By the way, this picture right here was taken on the beach with we're taking all our children in our care to the beach for a birthday party, just a combined birthday party for all the kids. And for a lot of the caregivers, this was also a day of respite. And for a lot of them, you think in Kerala, everybody gets to see the ocean every day. No, when you're confined to a house with illness, you don't get to see the ocean. So a lot of them were having just a great time going to the beach with their families, knowing that the entire palliative care team was there in case there were any medical emergencies. So a lot of the pictures that you might see today, that you are going to see today, are from our clinics. Okay. Now, I know this is a busy slide, but this is just to sort of reiterate the point that I just made, that when we talk about palliative care, we talk about life-limiting and life-threatening conditions. So the same thing applies to children, life-threatening and life-limiting. And life-limiting could also be a disability. It could be something that prevents the child from fully engaging with activities of daily living. Okay. And this is, like I said, again, this is just the spectrum of illnesses that we cover. And In India alone, we have about 9 million children who would benefit from palliative care, and less than 1% of those have access to children's palliative care. So this is just to tell you how much work is left to be done. And there is now an increasing awareness. There is the International Children's Palliative Care Network, for those of you who are interested in the latest resources, ICPC-10, and they're very active in the pediatric. I mean, that is their role. And you'll find a lot of resources in terms of toolkits, in terms of care pathways, all of that on that website. So I will direct you to that. I mean, we can send you the link to that as well. Okay. So while we talk about children's palliative care, we need to also talk about psychosocial issues that might arise from the fact that there's a sick child in the family, or it might be a pre-existing issue. Now, I know you've had a look at that slide, but what are some of the considerations do you think that are, more important to consider when it is children that we're dealing with, as opposed to, say, palliative care in the way that we are more familiar with it for adults? So what is more specific to children? Anything that comes to mind? Psychosocial issues, okay? Psychosocial specifically. Growing up, yeah. Age, developmental stages, yes. So learning about themselves. All right. Yeah, and the vast array of different kinds of disorders and conditions. I mean, there is so much out there that we just don't know. We tend to talk about palliative care and cancer, but when it comes to especially children, we're dealing with a lot of neurological conditions. We're dealing with things like chronic kidney disease. We're dealing with things like different kinds of dystrophies. I remember when I walked into the clinic one day and I'd never heard of Wilson's disease. And Wilson's disease is basically something that prevents you from metabolizing the copper in your body. And I saw this girl with these brilliant copper eyes because that's where her deposits were. And I learned more in the children's clinic than I did outside of it, of what are the different kinds of conditions that children really have to struggle with, and where, where that kind of support is needed. Language in which they're talked to, yeah, very, very important. Education. What do the families have to contend with? Like, what might be some of the possible scenarios? When you say education, Sudesh, I'm reading that as how education might be compromised. Yeah. Okay. All right. Indra, can you say more about the language in which they're talked to? What would you mean by that?
What I mean is that sometimes nothing is explained to the child as to what is happening, or what is this treatment being given to him or her. And I feel only some doctors are able to actually communicate with the child about their condition. And I was reading Dr. Rajgopal's Walk with the Weary. And what is quite amazing is that he's able to talk to a child who's curious about death. And, he says, they're able to take it provided you don't make it too complicated. So it was very interesting to me that, he was going to make that effort to talk to this child alone, who was all of 9, and wanted to know if when he's buried after he dies, will he suffocate? And he didn't want his mother around. So apparently Dr. Rajgopal said, okay, sit down. Let me tell you, after anyone's died, they don't suffocate. And that's all the child needed. He went away with that. So I feel that the language also has to be simple, but not running away from facts. I mean, what he wants to know should be told in some way that doesn't scare him or her. I mean, that's...
Absolutely. And we're going to be discussing that in more detail, just a few slides down. But thank you for flagging that. And I would say the problem is not just with the doctors, it's with the families themselves. And very often, if a doctor does want to speak with the child, it's the family that stands guard and says no. we don't want this child to be we don't want to talk to this child about illness. We're not going to talk to this child about how serious it is. They'd rather, we're going to talk about that. That's a very interesting area, and that is peculiar to children also. So I've seen something as simple as getting to chips, play with kids, not getting to do that. Yeah, they are not doing things that other children around them are doing or are allowed to do, right? And but then at the same time, there is no understanding because there's some gatekeeping happening. So those are some of the issues. Yes, those are some very vital issues. On a social level, there could be several other things as well. And I'm drawing mainly from my experience from our children's OPD, uh, I took care of that program for a couple of years. Um, the family dynamics, similar to in adult palliative care, family dynamics has a significant impact on the care that we provide children. How is the child spoken to, like Indra just talked about? Are they involved at all in the decision-making process? Are we asking the child what is comfortable for them, what is not? Or are we just saying, no, we are going to, and what happens here is we don't have shared decision making with children because we think children don't have the capacity for it. And much of that is true. It's their cognition is not developed to a point where they can make those decisions. Having said that, to keep them in the dark about what is going on with them, it could simply very well be talking about an intervention, like you said, in simple words. What does this intervention entail? It means that you're going to be in the hospital for a few days. Don't worry, we are going to be here with you. And is there going to be pain? No, we're going to try and make sure that the pain is as less as possible. So preparing the child for, what he or she has to go through, but that is seldom done. So we talked about 3 levels of decision making. Remember, in communications, we talked about information, just medical information, paternalistic approach, and then shared decision making. With children, we tend to be more paternalistic. That's all that happens. And when I say children, please remember it's up to the age of 18. Okay, so a lot of these are not children in the sense that they are unable to understand. A lot of them have had that cognitive development, but because they are children to us, we don't engage them in those conversations. I have seen a lot of single parents in this scenario, and that is a double whammy for that parent, because you have a single, first of all, it's a single parent, you have a sick child. There are many communities where, and this I've seen far too many times for me to call it an exception, where the woman is abandoned because she has given birth to a child with a congenital anomaly. And it is stemming from superstition. It is her fault. The fault is with her. So either she is then forced to have several more children to prove that, to make up for this, or she is abandoned. Okay. And there was one family which we took care of where 2 out of 3 children had cerebral palsy. And the mother was the only caregiver. And they wouldn't let her stop having children till she produced a normal child. And that was the ultimatum, because if the 3rd child was not normal, then the family would have left her. So there are and of course we're seeing this intersectionality of gender issues and things like that, but that is a reality that we cannot escape. And so single parents may face additional burdens, especially if the single parent is a woman and she has to go out and fend for the family financially as well as look after the child. And it becomes a very, very difficult situation. So they might need extra vocational rehabilitation so that they could do something out of their own homes, or they need financial assistance. And the needs of the siblings, we have so much, the spotlight is on the child who is sick, that the siblings become invisible patients. Okay, and they're either neglected, or they're expected to grow up very fast, or they're expected to, put their needs aside. Like, I want to buy this toy. No, we can't, because, your brother's needs are more important at the moment. Including siblings in the plan of care can empower them to contribute and feel more compassionate towards their siblings. And we've seen that happen, where on occasion we've had the sibling come in, and the physiotherapist has then taught the sibling how to do the exercises at home. And the sibling is very happy to be engaged in a way that is seen as meaningful, and is also now part of the, the whole caring team, and not someone who's just set aside. And I talked about this multiple children in the family having a condition, and it's very, very difficult, usually on the primary caregiver as well. What you're seeing in this picture is that we had a superhero day in our clinic, and we just before that we had done a toy donation drive, which actually had a tremendous response, and we had packages coming in from all over the world because we put out this story of this little girl who in the middle of a very stressful situation, we gave her those sparkly pipe cleaners. And there was this moment we captured where she forgot about her distress. And so taking that picture, we had actually just put it out on Facebook saying, hey, all these kids who don't even have access to toys, can you send across secondhand toys? People bought us new toys and sent us like earlier it was just so that we had toys in the clinic for them to play with, but after a while we got so many toys that we had to start giving them away. And a lot of people actually donated these superhero masks and stuff, so we had that little clinic there. And for that time, I do remember that this was in the children's wing of a government hospital, where you would usually hear children crying or screaming, but the palliative care unit always had a lot of laughter in it, and a lot of doctors would stop by very curious to see, why is this room the room where there is laughter coming out of? Isn't this the palliative care room? But this was also the only room in the hospital that had all of these other things going on at the time. So what that also really did for us is that it improved compliance. Children who hated coming to the hospital now suddenly wanted to come to the hospital to get their weekly checks, because it meant that they would get to play with other kids and have toys. So that is the power of that. So even if a family is really struggling, we can make the places that they come to for care be happier places, so that they are happy to come there. So otherwise, no child wants to be in a hospital around other screaming kids, and everybody's anxious. Okay. Now, other challenges, and these are big ones. You saw the numbers, what the demand is and what the supply is. And so there is basically a lack of access to care. And it's just that it could be because we don't have enough pediatric palliative care providers, which is a truth, or they could just be from a rural or underserved area. Now, a simple example for us is that we have an outpatient unit in Pallium, India and Trivandrum, and we also work out of the government medical hospital. And we have children coming to us from Tamil Nadu, from just across the border. Now, because we are the closest service. Now, what that does, and this lack of access and distance from care center, they're kind of interconnected. It means, and this happens so many times, where a parent has to accompany the child to our clinic. It means taking a train or a bus. It means an overnight stay so that they can come to the clinic. If they have other children, then the other adult has to stay back home and look after those kids and supervise that child who has not come. The other option is to bring both the kids along, which is an added financial cost. One, it is an added stress, especially if the other child is also very young. So these are the issues that just distance from a palliative care center or a center which gives them appropriate care can cause. So a lot of times what would happen is that the father and mother would both come, because the mother could stay in the hospital with the child. The father would then run the errands and do the practical stuff. Go and get the food, make sure that the prescriptions are filled out, etc., whatever. And in the bargain, they also had a second child that they had to look after. And that child had no option but to come to the clinic with the parents. It also meant a loss of daily wages, which then compounds the problem, right? So, and then to go back in a crowded train or bus back to where they came from. And with a lot of the children, so there was one child who, because of his CKD, had also developed bone density issues. And this child was one of the first children I encountered. He had 7 fractures at the time that I had met him, from his thigh bone to his hand to various other parts of his body. And this child, you couldn't pick him up because he had so many fractures. And they had brought him from, I think, 200-300 kilometers away on a local bus. So you can imagine the torture that this child has also gone through. And I think by the time this child finally died, and he was a very cheerful kid. And by the time this child died, I think it was actually a relief to the family because, I mean, it was just treacherous. That whole journey, every single time, was very, very hard on the entire family. And so he died, I think, at the age of 7. But the last year of his life, at least, we were able to give him enough, hopefully enough pain management. And the frequency of their visits also started to decrease. Either because their pain was being managed at home with the medication that we were giving them for, for a month at a time, or because they just didn't have the capacity to travel because of their financial cost. So these are some of the intersectional, I mean, these are some of the things we need to also consider when we talk about setting up these services and who are we serving through these services. And also to remember that it's not always about cancer, it is about a lot of other conditions as well. And we do have a very complex healthcare system. And uh, there is first of all, there is not enough information about children's diseases, rare diseases, or just about navigating the healthcare system. And so one of the major needs that families have when they have a child who is unwell is just somebody to help them navigate the system. And because it can be extremely overwhelming. And the thing is, psychologically, somehow you're also fighting harder when it's a child, right? So you're willing to go and see more and more specialists and more different doctors. So it's very hard to also then navigate that space. So a family, well, we call them patient navigators, but a navigator is very important to help the family think through what their options are. Okay. All right. Now, those are psychosocial challenges. Now, this is something that is very, very, I would say it's there in most palliative care settings, but it is enhanced in children's palliative care, where we're dealing with hope versus wishful thinking. Okay. Now, hope and wishful thinking, and I think this is important for us to remember across the board. Hope is grounded in an accurate assessment of the situation, while wishful thinking is a desire for unrealistic outcomes that may not align with medical reality. I'm going to read that out one more time. Hope is grounded in an accurate assessment of the situation, while wishful thinking is a desire for unrealistic outcomes that may not align with the medical reality. Now, here is something that we need to pause and think about, because we come across this idea of hope a lot in palliative care, right? So to make this distinction between hope and wishful thinking is very, very important, because when you encounter a family who says you're going to take away his hope, is it really grounded in reality? That's the question we need to ask ourselves, if not them. What are they hoping for? And is that hope grounded in reality or not? If it is an unrealistic hope, if it's an unrealistic outcome that they're hoping for, which does not align with the medical reality, that is wishful thinking. Okay, I'm just going to let this sit here with us for a couple of moments and just invite some reflections on it. Have you had these encounters where you have mixed up wishful thinking for hope, or encountered people who have done that? And what to you is the difference? It could very well just be that this is the first time we're having this conversation about wishful thinking and hope, so, and making that distinction. So just a sense of what your experience has been. I'd love to hear from you. Okay, so Lord, yeah, Aparna says, thought both are same. Yeah. Hmm. And hope is a very, it's a hard to capture word, because it means different things, right, to different people. But at the same time, um, I don't know if it can ever be fully objective, Shalaka, to be honest, because it is coming from a place of deep, whatever, longing for a particular outcome or whatever it might be. Um, the this is where communication also becomes important. If I don't have all the information, I'm more likely to uh, reach for wishful thinking. If I don't have the reality of my disease, if I don't have the reality of my trajectory, if that conversation, that Spike's protocol has not been used, if I've not been given the time to ask questions and be given honest answers, I'm more likely to veer towards wishful thinking. It's not my fault because I don't have the full picture. And this is not like we've said, this is not a one-time conversation. This is a series of conversations that need to be revisited over and over again. And we're not trying to take away the hope of the family. We're just trying to reframe it. Okay. We cannot hope for a full cure, but we can hope for good days, which are pain-free.
Yeah, and this
That,
is what I meant, Smriti, that when I say objectively, it could just mean, this weekend is going to be a good weekend. He's going to have a good day.
yeah.
Or, he could go to school probably for the next few days, or at
Yeah.
least twice a week or thrice a week. That is objective hope. He
Hmm.
can go play once
Hmm.
a week,
Yeah.
That is what I mean by objective hope. And I absolutely agree that if the conversations are not being had with the clinical team, that is with the doctors, then even other people like me or anybody else in the healthcare system, counseling them does not help. And honestly, with parents, I've seen that wishful thinking versus objective hope is, or versus hope is very difficult, very difficult.
It's
You show
very
them the
yeah.
guidelines, you have emotional conversations with them, you try to, even help them imagine worst case scenarios and also imagine the pain that the child would go through if you keep
Yeah.
intervening in certain aspects. Um, but it's very difficult for them.
It's much more difficult, I think, when it's a child involved. Because I mean, there are so many other complex emotions in place, right? And I mean, parents who love their children, I mean, they will fight to the bitter end, and usually it's a bitter end.
Also, it's this oncology versus everything else. In cancer, there's an immediate acceptance now that, okay, this is possibly not going to end well. And so, yes, we are more open to palliative services and the kind. But you take anything else, and no, they are not.
Absolutely not, and especially if it's a slow progressing illness, um, and it can be terrible. Now, and I noticed how fragile that conversation always is because we had these two children, and the first two kids I've made friends with in this clinic, and they've grown up now. And when they came in, both of them had juvenile rheumatoid arthritis, one worse than the other. And I think I've shared this story. And I remember sitting down with the mother, with the translator, to tell her that now this child is not going to walk ever again, the older one. And it that conversation okay, one was the language barrier, but even otherwise, because we were doing this conversation very carefully, the conversation took us about 3 hours, 2 to 3 hours. But there was a lot of space for, okay, are you to check with her if she's understood what we're saying, what it means in terms of lifestyle changes, what it means in terms of accessibility within the house, how do we need to improve that, etc., etc., etc. And finally, then following that, we had a conversation with this child. And the first time he sat in a wheelchair, we thought he'd be happy because he was now he was able to be independent. But actually, that was the day when he realized, my God, I'm not going to walk again, right? So he was 8 years old, 9 years old at the time, a little older. The younger one was 8. He must have been about 11. But he had accepted his fate. And a year later, he went to the government medical hospital, and a junior doctor told him, if we just replace your knees, you'll be able to walk. And then that became the conversation after that. And this is a child, by then we'd had a 4-year relationship with him. And he came to us and he said, why did you not tell us about this option? And we said, because this is not really an option, But it took that one random junior doctor to walk by and say that we had to rebuild our relationship with this child, which was a 4-year-old relationship. We had to rebuild it again. And it is irresponsible, Aparna. But then But what that also taught me is that hope is so fragile, especially when it's with a child, that any indication that there is hope, there's a better outcome, they will grab it. So that conversation goes back into a denial mode again and again and again. Okay. Duchenne's, yeah. Who kept with the belief that affirmation and positive thinking could reverse the condition. They read a book called You Can Heal Your Life. Oh, yes. And deduced every health condition is precipitated by your thoughts. Yes. And but I will also say that sometimes it is us as healthcare providers who are unable to have the conversation because it's about a child. And I think I may have also shared this story before with you, but we were called in for a CPAP machine for a child who had who had multiple conditions. And I remember prior to that, we'd been brought in for a similar request saying this child needs to be discharged from the hospital, but they need a CPAP machine. So bubble CPAP because the child is so small. Can we help them raise funds, so on and so forth? And it just seemed like, that machine was going to cost us about ₹1,00,000 and this child was not going to actually make it. So I had to make the very hard decision to decline that request, which did not go well with my team at all. The nurses didn't talk to me for 3 days. But the fact of the matter was that this was ₹1,00,000 that was going to, this child anyway died a week later at home. Okay. We would have extended that child's life by maybe another week or so. But that ₹1,00,000 also was required to go into medication for a lot of other children. So sometimes we're also caught in that space where we have to make those decisions. Now, so the second time this request came in for a CPAP, I thought, okay, it's going to be a replay of the last case. Then this child was in the ICU. And what shocked me was that the child had been in the ICU for 8 months and the mother was there every single day. She had not left the hospital. They had an older daughter who was 7 years old who hadn't seen her mother in those 8 months and was being treated for depression. And the saddest was, of course, that the ICU was a place of so much lack of compassion because it's a neonatal ICU. There was nowhere for the mothers to sit. And on one hand, the mother's touch is so important, but on the other hand, she can't sit down anywhere. And the baby's, that unit is at this level, at the chest level. And that, I mean, the cruelty of that whole scenario was a lot. And so eventually, the doctors at the ICU were like, I asked them, I said, have you had any end of life conversations? They said, no, how can we talk to the mother about that, etc. So eventually when we sat down and we spoke to the mom, she had known all along that this child was going to die. So we asked her, what is your one wish? What would you like to do? You want to take him home? What do you want to do? And she said, yeah, I want to just take him home and hold him so he can die in my arms, not with all these tubes. So she did exactly that. But it took 8 months to get to that point because we had assumed that she didn't want to have that conversation. When I say we, I mean the healthcare system. So these are very different. So anyway, the point of this whole thing is to say that this is an extremely fragile space to traverse. And all of us, not just the parents or the families, but also us as providers need to be careful when it comes to children. We also harbor wishful thinking. We hope for a better outcome for the kids. And reframing hope. So it's not about taking away hope. It's about reframing the focus of hope towards more realistic outcomes, such as comfort and quality of life at the end of life. And a lot of the times, wishful thinking is driven by need for control. Because you're careening out of control. There's nothing in your life that is in control anymore. Wishful thinking, a lot of the times, is driven by need for control. And all of those things that you said, right, Aparna, about, this book and this alternative therapy, etc. What is all this? It's a way of trying to gain some control over the outcomes. Right? You'll hear about some Baba or Guru somewhere who will do a jap and then, can miraculously cure. You will go because it's giving you something to work towards. And ultimately, bad news, remember, the gap between the expectation and the reality will determine how bad the fall is. That is this. So it can lead to increased distress when the desired outcomes do not materialize. And that is why it's not okay for us to go along with this wishful thinking. And the desire for continued curative treatment, often when medically inappropriate, is often more consistent with wishful thinking than with true hope. I want to underline that sentence. Desire for continued curative treatment, even when medically inappropriate, is often more consistent with wishful thinking than with true hope. And we must therefore balance that out for the family. And we need to reframe where we are constantly. We need to check where we are constantly and how we're communicating, what we are saying to the families that might be reframing that hope for them or going along with their wishful thinking. Okay. All right. And let's just, I'm going to stop sharing for a second. So any thoughts and comments before we move into the next section? Okay. What are some of the myths about children and grief, specifically children and grief or children and death? What are some of the ideas that we as a society harbor? Should we be talking to children about death and grief? I know this group agrees, but what does the larger world say? How many of us can go back and talk to our own age group people about death? Honestly, I mean, if we're lucky, some of us can, but most of us, it's not like such inappropriate dinner time conversation. So how do we have this conversation with children? Okay, they don't understand. So they won't know. So they won't feel. Correct. They don't understand is number one. They don't get it. बच्चे हैं, बच्चों से ये सब बातें नहीं करना चाहिए. Okay. They cannot process death. Okay. They shouldn't see dying person or death. Yes. It doesn't affect much. Yeah. Children are resilient. They don't, they'll bounce back.
Smriti, I have a personal anecdote on this.
Please.
I grew up with a very late diagnosis of a congenital heart defect. And when I was diagnosed, and I was smart enough to understand a lot of things the doctor, the cardiologist spoke to my parents about. And the first 3 consults, the cardiologists were like, she's not going to make it. It's already too late to fix that issue. And I could process all of that. They may have asked me to step aside a little bit or whatever, but I heard them and I could process that. And I remember the first 2-3 times I came home, and I used to have a nanny back home, and I declared to her, hey, you're going to be out of a job soon because I'm dying. and I said very casually, and I thought it's something exciting. So I was very aware about it. And then we also
How old were you? How old were you?
8. Yeah. And then when we met another doctor in Bombay Hospital, and he finally said, no, I think we can give it a shot. We should, do this. It's high risk, but we should still give it a shot, the surgery. And so a lot of things happened around that time, but no, not one person spoke to me about death. Not one person, addressed the things that were already in my head and that I was processing on my own. That I could understand risk in a certain way, not in the way adults understand it, but I had my own understanding of what it means to go through a risky procedure. What it means to go through a surgery, what it means to go through anesthesia. But nobody sat me down and talked to me like at my intelligence level. They thought she's stupid, which I wasn't. I don't think children are stupid at all. And I see this happening again and again because I also work with other parents and children with congenital heart defects. I see this happen again and again. And it is later when these children grow into adults that they complain, why were the doctors that way? Why didn't my parents sit me down and talk to me? Why did anyone ever have these serious conversations with us? Why didn't they respect us enough to be human beings with a brain that is growing, but we still understand things? Yeah.
That is, thank you for sharing that. I mean, that just illustrates everything that we're talking about at the moment, right? And I'm just thinking of, how often we are doing this without realizing it, and how many people are even aware of the fact that by withholding this kind of information or not going there with this child, to have that conversation, what damage it might do. And I mean, and it's not even about stupidity. It's about the fact that you just think that the child is not old enough to know or shouldn't know these things, because we have these ideas of what is inauspicious and auspicious, and inviting it if we talk about it and all of that. So there are so many barriers to it.
I
And
sorry. I also feel that parents themselves don't want to, they need time to process it themselves before they
yeah,
can vocalize to children. And I think they are never able to do that, you know. Uh, so in a way, they feel that if we utter those words, it's going to become reality.
yeah, exactly. Yeah, because as long as someone doesn't say it, it's not true.
Not
Yeah,
true.
I get that. And um I'm it's also it, like what Aparna also has just shared, that by the way, I love that idea of having a funeral for a class hamster. Um and you realize, in fact, the language that they sometimes use is stunning language. And we tend to forget that we were also children once, we understood things that were going on. Children know when there's tension in the house. Children know when there is sadness in the house. Children know when there is anger in the house. They know it. And we see it in their language, in their body language. We see it in a lot of these ways in which they express themselves, but we are the ones in denial because we don't want to go there. It's very uncomfortable. Yeah, Shweta, please, you have your hand up.
So excuse my voice, I'm a little sick. But I used to work at a cancer hospital, and once we had this patient come in, it was a couple. The father was sick for a long time. We've been dealing with him in palliative care, and he suddenly came. I think he had a cardiac arrest, and he came and he went into the emergency room, and the wife was immediately pulled in by the doctors to explain whatever was happening, right? And they had come with a 8-year-old son. So since I was there, I took him to the side and I went to the corridor and I was just sitting with him and engaging. And we were not talking, it was very quiet. And then after like around 5 minutes of silence, that kid asked me, like, is my dad dead? And I was like, and this was my first interaction with a child asking me questions like this. So I was like, let's just wait for your mom, let's wait for the doctors, because I'm not sure, because I'm also sitting outside here with you. So then he paused again. There was just silence. There was no more talking. And then he's like, dead means gone, right? And I was like, yeah, dead means gone. And then there was silence for another 5 minutes. And then after that, he just looked at me and he's like, I miss him already. And at that point, because it was the first time for me, I was like, how can an 8-year-old understand the concept of death so simplistically? And he said it like a statement. It wasn't to get attention. It wasn't to like, he wasn't crying, nothing. It was just a statement that I miss him already. And I think it affected me way more than it did him at that point. Because I was like, oh my God, this kid's going to grow up with the dad, but he doesn't understand. All he says is the emotion that he's going to miss him. So I think we also take it for granted that children don't understand death, but somewhere in the most basic, simplistic way, they do understand it. So yeah, I just wanted to share that experience since we were talking about it.
Wow, thank you, Shweta. That's really something. And I think every time a conversation like this happens, it surprises us. No, I mean, there's a wisdom that kids have, and dead means gone. No, I mean, how much more straightforward can that be? And here we are. We have all these euphemisms that we use, especially with children. They've gone to be with God. They've gone to the stars. They've become that star thing. I don't know. It's like um, that seems to be the go-to. But a simple, we will talk about this. There are some core concepts that I'm just going to touch upon. But thank you very much for that story, and thank you to the others also who shared in the chat box and vocally. Um, we could talk about this for a long time. Okay, so here we are. Many misconceptions. Most of them being around children are too young to understand. And like we just discussed, they understand more than adults realize. Children must be protected from loss and pain. Actually, what we're doing is we're depriving them of the coping mechanisms they're going to need for the rest of their lives. People are going to experience loss throughout their lives. And if we shield them from loss when they're children, what we're basically doing is we are taking away their coping mechanism, or we're denying them the healthy way to deal with something. So as in all things, as the child's brain develops and the child's emotional quotient is being sculpted or cultivated or whatever it is you want to call it, having these difficult conversations really models for the child how to handle loss and difficult emotions in the future. So if we deny them that now, we are actually setting them up for failure later on this front. Okay. And when children may not, going back to the story about the hamster, I mean, what a remarkable way that, when something dies, it's also an opportunity for people to come together as a community and share stories and remember. That in itself is a coping mechanism. You're teaching the children that this is how we handle death. And we handle it together. We handle it by sharing stories. Just 1 second, please. Sorry. And adults may fear very often, I don't know what to say. I'll say the wrong thing. The most important response is of honesty and compassion. And how do we do that? We'll talk about that in just a few minutes. And sometimes what happens is, we tend to say another way of shielding and protecting them is the person who has died, we're not going to talk about that person in front of this child because it'll upset them. But avoiding reminders of that person or avoiding talking to them sends the message to the child that it is wrong to think of the person who has died. That it is something to be kept mum about. It's very hush-hush. It's it's something very dark, or it's a place that we don't go to. And that, again, prevents the child from saying something that they need to say to process an emotion they might be having. And assuming a child is not grieving because they're not outwardly expressing it overlooks the reality that children will sometimes not express themselves because they don't want to upset you. Or, when there's been a death in the family and a child is noticing. So recently I experienced the death of a friend, and it was terrible. It was by and the children are young. They're 13 and 15 years old, and it was actually the younger daughter, who came upon her father as he had ended his life. And everybody is really worried about those kids now. But the children, I was unsettled by how composed they were. Absolutely composed. It's not to say that they're not grieving or they're not shocked, but the mother was falling apart. And everything that these children were doing was basically ensuring that the mother is okay. So they would keep going to the mother and saying, Ma, come on, we've got to get you to eat. Ma, come on, we've got to get you to do this. And basically what children will do is that they will delay their grief when they see someone in extreme distress. So please don't undermine how strongly children do that. They respond to adults. If they see that an adult is in distress, a child very often will delay their own expression or own processing to be there, and then it'll come out later. And we see this happen very, very often. And you will see this happen also in the sibling of the child who has died of a serious illness. The sibling will be the last one to grieve. Okay, so these are some myths, and we need to get over these myths. And now, coming off of these myths are these other misconceptions that children are resilient. They'll bounce back. And we need to remember that no, a child can have trauma for the rest of their lives if it is not processed properly. And they might be expressing themselves very differently, not verbally, not through conversation, but in their behavior, in their play, in things like that. And we often think that children don't understand death. They don't know what death means. But even very young children, like Shilaka said, have a have a more nuanced idea of death than we as adults think. And their comprehension may be limited, but they are actively trying to make sense of this concept. Please know that a child is always trying to figure this out, even if they don't have the tools for it to do it. And the idea that children should not express negative emotions is a terrible one, because children should be able to express the full range of emotions that people experience during grief, whether it is anger, whether it is sadness, because just like us, they need to process and work through these. Like, remember Worden's tasks of grief. You first have to be able to name it, to accept it, and then you work through the pain, and then you come out on the other side. Without doing that process, it is stunted. And if you don't create an environment where a child feels that he or she can express these difficult emotions, we are just setting them up for far more distress later. Now, this is an important concept. I'm going to spend some time on this slide. These are the important issues we're going to talk about when we are talking, when considering communication with children, okay? So the concepts of death. One, the irreversibility or the permanence, the idea that once someone dies, it is a permanent state from which there is no return. People who die are not coming back. Irreversibility. So like Shweta talked about, dead means gone, no? Is this? That's what this child is trying to process. Irreversibility. Okay? Inevitability and universality. That it is inevitable and it happens to everybody. Every living thing will inevitably die, and every living thing dies. Okay? So like that hamster, it's another living thing. It died, and we are now here to mourn it. So all living things. So oftentimes, one of the first encounters that a child will have is the death of a grandparent or the death of a pet. It is a great way to prepare them, not great way in that sense, but it is an opportunity to prepare them to understand these concepts of irreversibility, inevitability. You talked about this, Indira, and when Dr. Raj said people don't suffocate, okay, that comes under cessation. Okay, applicability, understanding who can die. Only living things can die. So you mean to say everything will die? So does that mean my toys will also die? No. Making the distinction between what is a living thing and what is not a living thing. What is inanimate, what is animate, okay? What is sentient, what is not. Cessation, that once someone dies, all body processes like breathing, eating, etc. stop. So you have no fear of suffocating because breathing has stopped. You have no fear of feeling pain because that has stopped. Okay. So this is an important idea to also develop your vocabulary around. And causation, very important. The understanding that death is ultimately caused by a breakdown of bodily function. So over a period of time, a child will say, okay, it can be external. I mean, I'll talk to you about that in the age development thing. But these are the 5 concepts of death, okay? Irreversibility and permanence, inevitability or universality, applicability, who can die, cessation, causation. Causation also is very important in children because very often they will connect themselves to the death. I thought, I wished something, so something went wrong. Okay. So any questions about any of these? And I think these concepts are actually useful to all of us at all given points in time. Because even if we're, of course, why we're talking about it in the children's section is because these are concepts we need to explain to a child. But even for us, when we have these conversations in our trajectories or prognosis concept. Yes, Indira.
Oh, I just, wonder, like, if you could give us an example of how you dealt with siblings of a child who is going to die. How do you convey to another child that his brother or sister is going to go?
Depends. Yeah, it depends on the developmental stage the child is at. So in the next few slides, we're going to talk about that, because how a child will process death is largely determined on where they are in their developmental stage. So there's a huge difference between talking to an 8-year-old and a 12-year-old. There's a huge difference between talking to a 4-year-old and a 6-year-old. Now, I'll give you an example. Very young children do not have the concept of abstracts and metaphors. They take things literally. So if I tell a younger child, oh, your grandmother went to sleep and never woke up, he's going to take it literally. Then you'll see this child is now becoming slightly insomniac, doesn't want to sleep. Okay. I've had a child when I've said, when I've sat in on a meeting and the mother has tried to say, no, your father has gone to be with God. And they're a religious family. Now this child is thinking, but if God loves us so much, he'll take us away. So I don't want God to love my mother. And this child is now resisting going to church. So you see how, but you see how this plays out. So we have to be very careful about the words we're using. So how would I prepare a sibling? It would entirely depend on, first of all, will I be allowed to have that conversation with the sibling? But there have been times when we've sat, and much like the Spikes protocol, Indira, I will ask them, what do they understand? What is happening to their brother or sister? And I'll take my cue from there. And I'm going to ask this child what it's been like for him or her. So it's a build up to that conversation. At some point when he says, okay, he's not going to get better, I still have to check, what do you mean by not get better? And children, the euphemisms they use are the cue for me to follow that same sort of vocabulary. That's very important. If they want to talk in terms of flowers and animals, I have to talk in terms of flowers and animals. If they want to talk in terms of stars and God, I need to talk in terms of stars and God. But at the same time, I need to understand I need to check their understanding of each of those concepts of irreversibility. Yes, he's not well. People who are not well, it basically means that their bodies are not working the way they should be working. You breathe using your lungs, or, this is what is happening this is what's working in you here is not working in your brother as well. Things like that. So I'll take my cue from the child. And I really need to know in the child's words what their concept is. So I hope as we go along, it gets a little bit more clarified. Yeah. Just let's go a couple of more slides further. Okay. Now, I want to take you through this, okay? The concept of death is evolving and growing. And from birth to 3 years old, children are pre-verbal. They don't understand words. They're pre-verbal. And their immediate needs are focused on emotional security. Okay. And they don't have any concept of permanence, finality, none of that. So their immediate concern is, I'm hungry, I need to be fed, I need to be around my caregiver. Where is my caregiver? All of those bonds are being formed. And also, interestingly, I mean, it's a very interesting time. We underestimate what is going on at that time. Human beings are the only species that most of the brain development happens after birth. Because we have, I mean, from a neurobiological perspective, the ability to to stand up straight and walk on our 2 feet, and to be able to do like all this prefrontal cortex stuff. Firstly, I mean, I'm just going to a little bit of evolutionary biology, but the human female species hips had to become a certain way because we as species stand up and walk. But what that does is, at the point of birth, the baby's head is the biggest, right? So the baby has to come out now, otherwise it's not going to come out later. And then in the first 3 to 4 years of life, the amount of neurological pathways, etc., being formed inside the womb, the same pace is being maintained outside. Unlike, say, a horse, where the calf will come out and start walking and is almost immediately doing its thing, right? It'll be a little bit wobbly for a little while, but most of its processes are in place. But human beings, the brain development is happening outside. Now, they may not have language, but there's so much synaptic activity going on that they're absorbing things from the caregivers and the parents and things like that. So their main concern at that point is a sense of security, stability, not too many changes in the environment. They get fed when they need to get fed. They get cuddled when they need to get cuddled. So that is why like 0 to 3 is actually an extremely important developmental time. And as they enter early childhood from 3 to 6 years, they start grasping some of the core concepts that I talked about, all that reversibility, etc. But fears and misconceptions come from limited understanding. They can't understand more than a certain point. That is true. And they may believe that death is caused by external forces like accidents, and that they can escape it, because this is also where magical thinking comes in. This is where their friends are, they're friends with the fairies, and they have imaginary friends, and they have superpowers and all of that. So if death is something that is happening externally, they can outwit it. Middle childhood, 6 to 12, they have a more nuanced comprehension, and then they start recognizing that death can happen because of external as well as internal processes like illness. And they may still, because they're still in that realm of magical thinking, they may personify death. Like, and that's why you have these symbols, what they associate as the Grim Reaper, or, some like the skull and bones or something. They have to have a symbol, or they have to have a personification of this figure, the boogeyman, all of that. And by the way, we reinforce it, right? Like if you don't eat your khana, you know who's going to come to get you. So that's also there. And at this age, they also believe that they can postpone their own death and things. So there's still a little bit of that magical thinking. But this is basically what we need to also consider. So Indira, to answer your question, it depends on where the child is. So if I'm talking to, I mean, I wonder how many opportunities I'll even get to talk to someone between the ages of 3 to 6 going through this. But at this point, the child needs reassurance, because security and safety is its primary concern. It needs some kind of, consistency in the environment. A huge seismic shift is going on, but what is going to stay the same? So my focus will be on what is going to stay the same. Okay. Middle childhood, as their understanding becomes more concrete, they may still have difficulty understanding the abstract and universal nature of death. Okay. And by late childhood, 10 to 12 years of age, they have a more mature and adult-like understanding of death. They understand finality, the irreversibility, the universality, biological causes of death. These are things that they understand it. Okay. And finally, adolescence. During adolescence, children develop a deeper, more sophisticated understanding of death. And this is also where they're also thinking of their own philosophy. They're thinking of mortality. They're thinking of, and you'll find that sometimes people here are taking more risks. They're indulging in very risky behavior, or they're almost, you'll find that there are children who, that's how their grief comes out, where they'll do reckless things. Okay. And they might have a heightened awareness of their own mortality and often struggle with the implications of death. So I'm going to be sharing all these slides with you so you can actually go into it. So a lot of this information is taken from a lot of different books and other experiences and journals and papers. But basically, a lot of different sources of literature, etc., have been condensed into these slides for you. So you can take any of these concepts and then read more about it. Okay, now it's very, very important to remember this. This is a very interesting part of understanding the child psychology around death and dying. Children will see them as the center of the universe. They'll see themselves as the center of the universe. It's not because they're selfish. It's because that's all the child knows. The child connects everything going on with themselves. It's not selfishness. It is just egocentricity. And you see it in the way a child will, if you ask a child for directions, have you ever asked a child for directions or to describe something? They will describe it in relation to themselves. Like, how long does it take to go to Nani's house? Oh, first we cross this, where that puppy, where we see the puppy. Then we cross the sweet shop. Then we go to this place. That's there. It's because they're relating it back to themselves, their needs, their likes and dislikes. They're not going to answer you as an adult. Or you step out of the house and at Shoelace Circle you take a right. That's not how they're going to say it. They're going to tell you in their own way, and you'll see what's important to them. So that's egocentricity. Now, the problem with egocentricity is that they also believe that they cause things. And sometimes you'll find that they're feeling guilty. I had a fight with mama, so now mama is sick. I wish bad things would happen to so and so, it's happening. They believe that they have magical powers like that, or they have powers that will influence, the forces of nature. And it's not, it's just part of, I mean, if you remember yourself as a child, what stands up for you in terms of egocentricity? So egocentricity is that they think that everything in the world is connected to them, and therefore it can lead to feelings of guilt, self-blame, anger, and it's important to acknowledge what a loss means to the individual child. Okay. And help them understand that death or illness is not their fault. Now, in the example that Shweta gave, he's understood that it is irreversible. This parent is not coming back. I mean, in his idea that his father is dying and he misses him. Okay. Now, if it has been a complex illness, if there's been conflict in the family, if there has been, you sense that there's been a little bit of neglect of the sibling, I would spend some time here, Indira, to how are you feeling at the moment? Is there any guilt? Am I picking up any guilt? Because does this child feel that he or she is responsible in some way? And the guilt will also be that, oh, my brother or my sister was always the favorite child. They interpret attention, medical attention being given to their sibling as a preference. Okay, they don't love me as much as they. And you'll find that this child is trying to get the parents' attention by doing other things, sometimes not very acceptable things to the family. Okay, every child has a fear of abandonment. And illness or death of a family member can threaten a child's sense of safety, leading to fears of separation and loss. And it's crucial to find out exactly what the child fears in their own words. My mother's going to die next. God loves my whole family. That means my whole family will die. On one hand, like my grandmother has told me, God loves me, I'm God's favorite. Oh, hell, I'm next. you know so also abandonment issues, you'll find that a child will get more clingy to others in the family. That's because that's basically showing you that they're worried about being abandoned. Okay. And a child will create order out of chaos. Those of you who are gestalt psychologists know this. In the absence of appropriate information, you make sense of with the pieces that you do have. So in the absence of appropriate information, children will try and make sense of death and loss by creating their own reality made up of fantasy and half truth. Why is it important for us to talk to children about what has happened? Is if we don't, they will fill those gaps with things that might be even worse. Okay. And so get a sense from them. What do they know? How much do they know? And where are some of their misguided ideas coming from? Okay. And if you remember the story I told you about that mother who was in the ICU with her little baby for 7 months, and her daughter was depressed. What do you think was going on in the daughter's mind? That this baby has come and taken my mother away. I never see my mother anymore. And this child, so the daughter was 7 years old. So 7 years old. She has some idea of these concepts. But she's also in that phase of magical thinking. Mother went to the hospital to deliver a baby. She was supposed to come back with a younger brother. She never came back. So what has happened to this girl? What happened to that girl in that period was she was a good student. She started flunking in school. Okay. So it's important for us to remember these things, not just from the point of view of the child who's undergoing or who's living with an illness, or who's living with a life-threatening condition, but also what is happening with the other children in the family along these same lines. Okay. Okay, I'm going to move along a little bit faster now so that we have a little bit more time. And it's important for us to remember that simplify and clarify, provide truthful information to children in a simple and clear manner, and repeated explanations may be necessary. As a child goes from 3 to 6 years, 6 to 8, or 10 to 12, they might, because their concept of death is evolving and it's changing, they may come back to the family, as they grow older, to say, hey, but what happened exactly over there? What happened when you say grandma died of cancer? Does that mean that her organs started to fall apart? Like, what is going on there? So the children will come back to you as over a period of time, and they will remember whether it's a parent they've lost or a sibling they've lost. They might need to come back to you with questions over the period of developmental stages. And if you have that connect with the child, maybe you want to revisit those conversations during anniversaries or birthdays or some sort of a milestone event, where if you have a little prayer service for the person who has died, it's a good opportunity at that time to really sit with the child and revisit where that child might be with that sense of loss now. Girls, I mean, I know of a girl who, when she got her period, is when she really, like, she had a huge reaction to her mother's death. Her mother had died when she was 8 years old. But when this girl got her menstrual cycle for the first time and the mother was not there to explain it, that whole thing came out. So, so at some will experience it during childbirth and pregnancy, when they don't have a mother figure to shepherd them through a time like that. So you have to see the developmental stages, and I ask you to invite a child to talk about what that loss means now compared to last year. It will change. Okay. And let the child lead. Remember when we said in the communications class, let them set the agenda, or find out what their agenda is. So let the child lead. Allow the child to set the pace and the agenda. They may need to revisit the same questions multiple times to make a sense of information in new ways. Okay. And understand time perception. Time to children is not the same as time to us. For them, today is now, soon is hours away, and tomorrow is years away. So when you're talking about, things will feel better in time and all of that, please remember that the concept of time for children is very, very different from ours. Have you sat in a car on a long distance road trip with a child? It is a very long drive for all people concerned. But yeah, so time changes, moves differently in a child's mind. Okay. Now, we've talked about concepts. We've talked about egocentricity, chaos, finding order in chaos. We've talked about fear of abandonment. So what does a child need? How can we actually be around children who are going through a difficult time? One, they need reassurance. And how do we reassure? We reassure them by giving them straightforward answers. Now, or answer their questions. And this is something that's very interesting. Okay. Children may ask seemingly simple questions like, can I have my sister's toys now? The sibling has died. The sister has died. Now the sibling is saying, can I have my sister's toys now? Or they will ask you a question like, so who will take me to school? The father has died, or the grandfather has died. Okay. These are not just practical questions, but landscape questions. And what they're trying to do is restore familiar landmarks and routines to their lives. They want a sense of stability. So like what I said earlier, huge changes are taking place. The child needs to know what will stay the same. Can I have my sister's toys now is also something else. Can I have your attention now? Now that my sister is gone, can I have your attention? Can I take my sister's place now? That is the question there, actually. And sometimes it comes across as a very selfish question, no? Oh my God, your sister just died and you want her toys. No, please understand what this child is asking you. She's asking you, can she take her sister's place now in your universe of attention? Okay, and this is something that we need to also educate families about, that a child will come out and ask you a ridiculous question like that. Please understand the emotion behind it. Okay. Older children may have longer term questions, like, what will I do on the holidays now? Because we used to go to Nani's house, right? Nani's not there anymore. So now what are we going to do during the holidays? And will I be able to go to college? Because, hey, there's no more money left in the house after all the treatments. So the child is seeing that, the lifestyle changes that are taking place. We're not being able to afford the treats anymore, et cetera, et cetera, et cetera. Will I be able to go to college? Is there a way of asking, am I still secure? And it reflects their need for reassurance about the future. Okay. These landscape questions are, now I want to feel safe now. Those questions are, I want to feel safe in the future. And providing steady support. Children need steady, reliable reassurance from the adults in their lives. And you have to answer their questions with empathy and not with ridicule or not with dismissal. See where that question is coming from, where is that emotion coming from, so on and so forth. Okay, that's the first thing they need, reassurance. The second thing they need is to be able to express their feelings. Okay, and they will often express grief and other difficult emotions with behavior rather than words. So give them a space, give them art and craft, and you'll find that there's a lot going on with the child. And you'll see it in their art, you'll see in the way they play. And it's important for us to purposefully observe those particular aspects. Okay. They need to be able to release their energy physically, because children are very physical beings. Okay, so running, playing, all of those things, if they're grieving, it's a time when you have to encourage them to play. And it's because it's a time of such sadness in the household, they have to be given permission to laugh, that it's okay for them to go and have a little bit of playtime. It's fine. We are here, we're handling this. Now, going and laughing and playing with your friends does not mean that you've forgotten the person who has died. So you have to explicitly sometimes give them permission to do that. And older children might find it helpful to write stories or letters or other forms of creative writing to express their thoughts and feelings about loss and grief. And this can give them a valuable way to express their emotions. So writing a letter to a loved one, or and if they're not fond of writing, then perhaps just creating a story or something of that sort. And sorry. So those are just some of the ways in which we can help kids. And I'll just, one sec, I'll just stop sharing here. And also I would say that, we've covered it in the process. One of their biggest needs is information, right? So children who don't have that information, they're trying to make order out of chaos. Just like adults, without adequate information, they're not going to be able to process difficult emotions. So information, reassurance, and permission to express themselves. These are the three things that we can support kids going through a difficult time. So we've covered a lot. We still have 10 minutes. So I want to just check how everybody's doing, because this has been a heavy topic. And I just want to hear from you whether you are able to apply any of these things in the scenarios and settings that you're working in, or even within your own personal lives, or if anything has struck a chord with you in particular. Parents, aunts, and uncles. Yeah, so I'm reading Aparna's comment of parents and teachers associate being bad and naughty with a negative consequence. Hence, children tend to associate serious illness and death with something they possibly did wrong. Yeah, and so that egocentricity is reinforced by the adults. We often try to discipline our children with using fear as, a fear of something bad happening. And we forget how much children are absorbing at that age. So some very casual remark from 3 months ago will suddenly emerge now and say, okay, it happened because I was naughty then. If I've hidden and gone and done something naughty and my parents have not found out, and then immediately after that or sometime after that, someone in the family falls sick, I might think of it as punishment. Yeah. Yes, and Narmada, absolutely. So much. Sometimes, I mean, that's what I think, I mean, it's going into this particular field with kids. Ultimately, all of us also have an inner child that needs to be nurtured, and we need to be given permission to express ourselves in a particular way. So all of this stuff is as applicable to us, right? And we might say, oh, children don't understand or whatever, but we have similar stereotypes for adults as well. Oh, she works in palliative care, she sees death and dying all the time, she should be able to handle it better. Yeah. Or even this idea of celebrating resilience as resilience, it's great, but the idea that someone has to be resilient all the time, or she's the strong one, or that person is the rock of the family, these are very difficult and heavy things to carry. And with children, that's the other thing. Going and telling, a young boy, you're the man of the house now. You are stripping that child of his childhood. Or you telling the older sister, okay, mama, or you will take care of the kids, right? Like mama did. Again, you're enforcing these roles, and they will internalize it and they will rise to those roles. So we actually craft their narrative for the rest of their lives. So those are things, and I know we say things like, okay, be strong, be brave. How many of us say, hey, no, you know what, just cry? Even when we offer condolences, we wish people strength, we wish them those things, right? We should also be able to offer a safe space for them to be vulnerable. So I would say we all need to check our value systems a bit, and what we are enforcing on other people by asking them to stay strong, be brave, all of that, because we're not giving them permission to actually process grief in the messy way that they probably need to process at the moment. Okay. Okay, so if there aren't any other questions or comments, we can wind up now, I think, Shri. I will share this PowerPoint with you. I will do it after I add some citations to it, so that those learning materials can also be accessed, or those resources can also be accessed. Yeah, Narmada, you want to say something?
Yeah, I have one question for you. So I realized that a lot of children who are undergoing palliative care can still try to go to school, right, or participate in activities, but it requires constant interaction with the schools about what their needs are. We talked about disability recently and how access prevents, you know, uh, community care. How would you handle it? Have you had cases where you had to interact directly with schools? Do you have examples of that?
Yes, we have had to directly interact with schools. We've had several occasions where, like for instance, this little boy Rahul who transitioned into a wheelchair, we had to speak with the school about that. There's been another child where, even something like having a catheter and having a urine bag, and like having somebody in the school keep an eye on those kind of things. For this little boy, they actually moved his class to the ground floor, because then he could access it. Otherwise, whatever, his class was one flight up. So while they couldn't, obviously it's not a very well-to-do school and they can't make the whole school accessible, but that simple thing of switching classrooms so that he could attend, or to have certain class. So it entirely, I think, depends on how we are able to speak. And I find that schools are quite often they're receptive to this. It's just that they don't know. I mean, it's not their job to know about how the symptoms play out and stuff. So I think it's a two-way communication, and it also helps to sort of educate. I mean, this is an ideal situation, but it also helps to educate the classmates of the child about what might be going on. And very, very importantly, especially in some settings, inform the parents of other children that this is not a contagious illness. It is not it's not something other children can catch, because there are a lot of people think cancer is contagious. So, just so, because what happens is you have one child going home and telling his or her parent that, okay, I have this sick child here, then all hell breaks loose. And then it comes back to this. So a little bit of psychoeducation, a little bit of practical education, even maybe if you are able to, then go and sit with the other kids and, maybe teach them the vocabulary of how to talk to this child, so that the child does not feel like isolated or like a special case or whatever it is that sometimes happens. Yeah. So we have had occasion where in fact, our education support team, Shri, is constantly in touch with schools, no? Especially when we're trying to establish, okay, in that case, it's not always children who are undergoing palliative care services themselves, but children whose parents are. But even then, there's a lot of sensitivity around the fact that this child is going through an emotional upheaval. So to be mindful of that, right? So yeah, there are many ways you can do it. Yeah. Some children will, like, for the teachers, it's important to say that, because this is how the symptoms or the disease impacts the child, or the fact that there is a sick parent in the house or whatever else, they may need to spend a little bit more time with that child, extra classes or whatever, because you're not in a learning space when there's so much turbulence going on. Yeah. I think there was one more question. No. All right. Okay. I think we're top of the hour now. You can write into Shri for any other questions. I will try and populate that slide deck with as many resources for you as possible. This is a really fascinating area of study, and I hope those of you who are entering it for the first time will take it on. Okay. Thanks and good afternoon.
Thank you, Smriti, ma'am. I think I should now prepare the certificate for you to end the sessions on time. You are keeping up the. Well, really, thank you so much for joining us. Thank you, everyone, because all the sessions have been so much interactive, so much informative, only because of you people. Thank you so much for that. Because without you interacting, it would be a very monotonous thing. So thank you so much for that. And with the promise that we'll be meeting again in the next session with another eminent speaker. This is Sri Priya, along with Ms. Smriti Rana, signing off from the Tipsy Go. See you in the next session, everyone. Till then, take care. Bye-bye.